Welcome to This Week in Health IT. It's Newsday. My name is Bill Russell, former healthcare CIO for a 16-hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Special thanks to Sirius Healthcare, Health Lyrics, and Worldwide Technology, who are our Newsday show sponsors, for investing in our mission to develop the next generation of health IT leaders. Your response to Clip Notes has been incredible, and why wouldn't it be? You helped create it. Clip Notes is an email we send out 24 hours after each episode airs, and it has a summary of what we talked about. It has bullet points of the key moments in the show, and it has 1 to 4 video clips. So you can just click on those video clips and watch different segments that our team pulls out that we think really captures the essence of the conversation. It's simple to sign up. You just go to thisweekhealth.com, click on subscribe, put your information in there, and you'll start receiving clip notes after our next episode airs. It's a great way for you to stay current. It's a great way for your team to get to stay current, and a great, really, foundation for you and your team to have conversations. So go ahead and get signed up, get your team signed up, and begin getting clip notes after the next episode. Today, we look at patient matching, tech to address health disparities, price transparency, the marketing challenge that healthcare faces to get to the 80% vaccine threshold that we're looking to get to. So a lot of good stories with Ed Ricks, Director of Healthcare at Sirius Healthcare. Since Ed is on the show, I should call out that Sirius is sponsoring the show as well. Welcome to Newsday, Ed.
Hey, thanks, Bill. Appreciate it.
Well, did I call that right? Do I call you guys Sirius Healthcare, or should I call you Sirius Computer Solutions?
Well, so we're both, but we try to brand ourselves Sirius Healthcare because our team, that's our entire focus, is healthcare.
Well, yeah, you have a healthcare, a lot of the people I've talked to, Vic has a healthcare background and Fred has a healthcare background. You have a significant healthcare team that is focused on the challenges that healthcare faces. And some of our CIO guests have talked to me about some of the things you guys have helped them with. And you really do address a broad range of things for healthcare companies.
Yeah, I think, probably our overarching strategy is really that we're just trying to solve problems with solutions, not technology. It takes a lot of technology sometimes to make those things happen, right? But the hospitals, the clinicians, the patients shouldn't have to think about that.
Yeah, I gave you that little segue because it's interesting. Sirius is one of the most amazing sponsors to me because they don't want any fanfare. It's like, just mention our name. We just want people to know that we support your mission, and that's really enough. And it's really kind of crazy to me. I'm like, do you want me to read an ad? Do you want me to talk about the services you offer? Like, no. We just want to support what you're doing. And so I've really appreciated that. I just wanted to give a shout out to all the things you guys are doing. So,
no, wait a minute though. I'm looking out my office window. I'm waiting to see the airplane go by with a banner or something. So we'll take a little fanfare, but.
I don't know. You guys are pretty low key, but you show up everywhere. Every time I'm talking to a client, they're like, I'm like, well, what are you doing in this area? It's like, well, we brought Sirius in, and those guys are helping us with our build out of our, patient room next and those kind of things. So it's really interesting, the stuff that you guys are doing. Yeah. All right. We should get to the news. Otherwise people will think the whole show is about advertising and it's really not. We actually only have, I think, 8 advertisers on all the shows that we run on This Week in Health IT. So we're really kind of lean in that area, which is great. You know what, let's start here because it got a lot of traction. Last week I did a post on LinkedIn, and I haven't been checking LinkedIn recently. So I want to do that because I want to keep pulling the community into the conversation. And it really was a lively conversation. And if you want to engage in the conversation, go ahead and follow me on LinkedIn, Bill J. Russell. I throw a post out there every day. It's usually a news story. I usually follow that with a Today Show. And then you can read just the post I do on LinkedIn. You can read the article that's connected with it, or you can listen to the full Today podcast and get more information. But this one was Cerner Corporation launched a program with MIB. If you're not familiar with MIB, it's not Men in Black. It's actually a clearinghouse, if you will, for information to insurance carriers, really life insurance carriers. And Cerner announced that they will provide MIB access to 54 million patient records via MIB. At least that's what the headline read. And it's a really poorly written headline because it's not like MIB all of a sudden has access to 54 million patient records. It actually is that patients will have the ability, if they are getting a life insurance policy, to do patient-directed interoperability and say, send my record to MIB or send it over to New York Life, and that will expedite the process. Because regardless of if you do it electronically, you still have to do it. So if you don't do it that way, you have to go to the electronic medical records part of your healthcare organization, get the information, and send it over. And the last time Cerner did this, which wasn't that long ago, was probably about 2 months ago, they did it with New York Life, and I did a little post on it. And you would think that Cerner had betrayed the trust of patients everywhere, and people came out in earnest in that post against it and just said, you know, how could they do such a thing? And it's interesting, in this article, they made it very clear that MIB had already done this with Meditech and had already done this with Epic a couple of years ago. And I thought it really put things in a different light. Did you get a chance to look at, I mean, I'm sure you saw that post. Did you get a chance to look at this? And do you have any, I'm going to read some of the comments we got on this, but what are your thoughts on this?
Yeah, no, I did take a look at it. And, you know, again, everybody's so worried about like Big Brother having all this infiltration in their life and what they're doing. And they miss what's really happening, right? In some of these cases, you're trying to make people's lives easier. And I think that's sort of the goal of technology if we use it right. So while the goal is the right thing to do, I think what they're doing is the right thing to do. The public perception is always the wrong thing, you know. And I saw some of the comments on your LinkedIn post and just reminded me of like if we do the same thing with the healthcare organizations and the payers to improve prior authorization, claims processing, that kind of thing. At first, I think people were hesitant, but when they realized, you know what, if we have this kind of connectivity, we can have prior auth and get paid maybe day one on some of these claims. That's what some of the payers want to do. And so that's a different way to look at it and sort of easing what's going on from a technology perspective. You've been to some of our healthcare to healthcare events, you know, so they're all peer-led events with CXO people in the room and from all different kinds of health systems. And usually we've got one or two from a large payer that come to that also. And so you see this distrust, you know, one of our favorite CIOs, physician, you know, had this distrust for payers because of the experience as a provider over the years. And then they talked about, you know, sharing the data real time for these things. And you could just see, no, you shouldn't get our data like that. And then when the payer says, but our goal is we maybe can pay you that same day for the claim, all of a sudden, like the light bulb goes off and say, all right, I get it. You know, if we can share that data to improve what we're doing, I think that's better for everyone. And then I don't see any difference for the life insurance. So same thing. You're going to submit it. You used to just attest to that information before, and now you got to submit some real data. So why not make it smooth?
Yeah, my test on these things is always, does value accrue to the patient, and is the patient in control?
Right.
That's my lens for which I look at all of these things. And it requires a patient-initiated request for that record to move to MIB or to New York Life. So that clicks my one criteria. And then the second is, what does the value that accrues to me as the patient? And the value that accrues to me as the patient is, I don't have to track down my medical record. I don't have to go over to all. Look, I didn't go to one health system. I've lived in 6 states.
Right.
I literally have to go to 6 different states, 6 different health systems to get my medical record. I mean, that's literally probably taking 20 hours out of my life to collect that information and send it over to my insurance carrier just to get a life insurance policy. Let's hit some of the links to see if there's. So David Chow posted a link to the 2018 agreement between MIB and Epic. Margarita Kalezov, and this is the hardest part of this, reading people's names, asked, is this reciprocated to the patients? Will they get access to their own information too? You know, that's an interesting question. We created a way to share a significant portion of the medical record with MIB and New York Life. You would think that sharing it with the patient wouldn't require that much additional programming, at least as much additional programming as we were led to believe in the interoperability debate that would have been required to share it with the patient. I mean, if we create this mechanism to share that information over there, in theory, I mean, am I thinking right or am I off base here? In theory, couldn't you just use that same code and tweak it a little bit, put a some sort of security and identity framework around it and share that information with the patient directly?
I mean, it's the patient's medical record, right? So they should have access to probably all the elements that are going to go over there, I would think, already, one way or another. I'm sure the mechanics of what's being sent over through interoperability is different than what a patient could ingest. But like you said,
Yeah, I don't want to let common sense and logic to really cloud our thinking at this point, but it would seem to me that if you're building it for one mechanism, you can easily, if your programmers are any good, you're using reusable code and blocks and those kinds of things. It should be easy to do. Lee Milligan chimed in. We've had this in place for a long time, and it's a definite time saver for medical record staff. And that's pretty much the primary objective that everybody talks about. So that's somebody on the front lines whose medical record staff is using it. Jim St. Clair, Chief Trust Officer at Lumedic, writes, Cerner Corporation will provide life insurance access to 54 million patient records. That's the title. Therein is the cultural problem. My credit union doesn't send press releases saying they're granting access to my bank account in other organizations, but we've accepted this as okay in healthcare. There's as yet in this country no cultural impetus that ownership of this data is sovereign with the person, not the system. And a couple things. One is he really goes off on the title, and I think the title was misleading, which is what led him in a interesting direction. And he and I went back and forth a little bit on this. But I think the other thing is, and I just need to call, almost every time I have this conversation, I just need to call it out. In 49 states, the patient doesn't own the record. It's not your record. And people always get frustrated with me. It's like, no, it's my record. It's about me. No. The creator of the record owns the record. And you didn't create the record. Even though it's about you, the record was created by the health system. The health system owns the record. The EHR provider doesn't own the record legally. And the patient doesn't own the record legally, except in the state of Vermont. It is not the law that you own the medical record. It is the health, it's the creator. Now, the question is, should we have joint custody? And I think that's the direction we should go. Sure, if the health system's going to create the record, they should own the record. I'm all for that. That makes sense to me. But I want joint custody. I want the ability to get access to the record so that I can start to engage other organizations on behalf of my health. If I want to use big tech, if I want to start signing up for Apple programs and something that Amazon does, and maybe I don't know, a Livongo or a Teladoc, and I'm going to start going out the normal channels that I do. I really want joint custody of my record so I can give it to the players that I choose to create as my health system ecosystem. Now, again, I just need to check here. Am I smoking something, or does that make sense?
No, I mean, I like it. The thing that you have to be careful of is, while patients can request to change their medical record, I don't think you want that carte blanche, right? To have a patient be able to update a record because it's theirs. It's both of ours. Only the health system can update it. Some people say that's not right. It's my record. I want to update it. I might have said I'd take 8 drinks a day, but I really only want to put in there 3 drinks a day, or 1 or 0 or whatever it is, whatever it might be. And so I think it's okay to request a change. There is a format and a process for that. You have to be careful where that goes.
Yeah, and we created some tools for patients to give us information, and we always had metadata around that said patient-generated data,
right,
so that the clinician or administrative staff that was looking at it understood where it came from, and they would determine whether it needed to be verified or whether it needed, what level of credibility. By the way, we had metadata around provider data, provider-created data, because some of our doctors said, look, if data is coming from that doctor, I don't trust it. I kid you not. I mean,
right, yeah.
And if you've been in healthcare long enough, you've heard those statements. And so they would say, look, we need to know if this is generated from within our health system or from a partner and so we create metadata around the actual data all the time that says, this is the source of this data, give it the credibility that you're going to give it.
Right.
So some called for informed consent on this article. Some actually called for a complete end to the electronic medical record altogether. Yeah. So, I love the discussion. I'll tell you, one of the things that's apparent to me is that Epic's clients defend Epic. They aren't seen as a corporation. They're seen as Judy. They're seen as a person. They care for them. Cerner is seen as a corporation. The two of them do the same exact thing, and one is seen as helpful and the other is seen as villainous. And that's just an observation on my point. I don't really want you to comment on it because I can get in trouble. I don't want you to get in trouble. But I'll tell you what, if people want to participate in the conversation, go ahead and follow me at Bill J. Russell on LinkedIn, and love for you to participate. So we have a bunch of different stories. Let me hit on one of the ones that I think is really fascinating to me, and that is Teladoc. I'm not sure I shared this story with you. I should have. So Teladoc announced, and this is recent. Actually, this might even be this morning. It is this morning. Teladoc released their Q1 revenue, and it more than doubled to 454 million as telehealth visits continue to climb. Let me give you a couple of excerpts since I didn't share this with you. Despite a historically weak flu season, the telehealth giant delivered 3.2 million virtual visits in the first quarter of 2021, up 56% compared to the first quarter of 2020. Earlier this month, the company launched its first wave of members to access and register for the Livongo programs, which is their recent acquisition within the Teladoc app, marking the first step in creating a seamless member experience to engage their members more effectively across programs, said their CEO. The company also launched a medical group referrals into chronic care management program and a major new contract with a regional Blue Cross Blue Shield plan on the East Coast. The number of consumers enrolled in more than one chronic care program tripled year over year, which indicates users are choosing Teladoc Health to meet broader health needs beyond urgent or episodic issues, according to the company executives. Total U.S. paid membership is expected to rise between 52 million and 54 million members. Teladoc expects to deliver more than 3.2 million visits in the second quarter, possibly up to as many as 3.4 million visits. I'm sure you're following telehealth, and telehealth is the conversation with a lot of health systems these days. That still, those numbers are pretty staggering to me. I mean, that their numbers have doubled in Q1. We knew that they doubled last year in Q2 with the rise of the pandemic. Everybody went to telehealth, but this would indicate that telehealth's trajectory is still on the rise.
Well, I mean, guess what? Everybody figured out what you and I have known for 10 years, that telehealth is really probably a better way to deliver medicine, and healthcare. I think the payers always knew it, although they didn't always reimburse for those visits, but they knew intuitively it was going to be less expensive, probably, get quality care, physicians, get them on board a little bit. So I really personally hated all these discussions in the last year, probably since the pandemic started, of look at all the innovation that people have come up with to sort of respond to what's happening. Most of it I didn't see as innovation. It's just like we're adopting the things that we already had available. We're just doing it really, really quickly, and folks are getting on board. So, those who were resistant before had no choice, right? I mean, we had to evolve telehealth a little bit last year, and I think you're just going to see a mushroom because it's easier. It's better, I think, and for a lot of things. Some things you got to have hands on, but for a lot
so
of
Ed, let's go back and forth a little bit on this. Why is it better? Obviously, it's got to be more efficient, right? I can see more people. I can have a larger panel, I think, is one of the things. I could see more patients via telehealth than I would in person. Just the logistics of it would make sense. Are there other areas where it's just better?
Yeah, well, I mean, I think the logistics for the patient too, right? So in many cases, you're looking at minimum 30 minutes each direction, plus wait time in an office or something. In some cases, it's an hour, depending on where you live or where you have to go for a specialist or something. So if you can eliminate that, improve that patient experience, that's a win, right?
Yeah.
It's clearly more affordable. If you look at big picture, what the cost to deliver care is, you don't necessarily have to have all these bricks and mortar buildings anymore. We still have them. I've been amazed at how many new facilities that are still going up today, which is incredible to me, because I feel like if you're thinking 5, 10, 15 years down the road, care is going to be like super, super, super acute care, and then home-based somehow, or, some different level of care to deliver the same thing we do today. So that's got to happen, but it's
and that might fall into the same category as we saw telehealth 10 years ago, and it's now coming to fruition. It's like we see home-based care, and we see alternate ways of delivering care today, but it might take whatever, pandemic 2030 to really, I don't know, catalyze our movement in that direction. I don't know. I hope not.
It's got to change. I think it is. I mean, a lot of people are working on new programs that can help with that, I think. But I just think that telehealth is going to be more efficient. It's got to be. It's definitely a better experience, even for patients who were resistant before, and probably more importantly, physicians or clinicians who were resistant before. And IT can manage it, and there's great vendors out there. You talk about one, but there's plenty of others that do a great job in that field.
It sounds like your dogs want to be a part of the show. Is that what's going on?
I'm sorry. That's like our 3 wireless doorbells, laying on their charging mats until the UPS guy happens to be brave enough to come up the driveway or something.
This is the world that we live in. How are health systems, do you think, today really, how are they integrating it? How are they pushing it forward? I mean, Teladoc sort of stands over here on its own, but how are health systems really looking at this? Where are they plugging it in? Where are they trying to expand it? And as you said, it's not perfect everywhere. So where are some areas they're pulling back and where are some areas they're pushing forward?
Yeah, I think the traditional model was like either the real telehealth, like stroke to a tertiary center to a community hospital, something sort of that telemedicine with internal. But then people started, probably the biggest thing was urgent care visits, right? You could do a Teladoc, an EMWell, some of those other vendors, and just sort of relieve your ER, hopefully, of patients who probably didn't need to be going in there to begin with. But now you're seeing a more full adoption. I think the challenge is going to be, like, as we all grow, what data do we want to collect out of that visit, that virtual visit? Where does that go? Is there home-based data that's going to go in that? How do we use it? How do we store it? As you mentioned before, put metadata around stuff because it may mean more to a clinician or it may mean less to a clinician if it came from the patient end or the home or something too.
Yeah, I like health systems doing this work as opposed to a third party because it integrates the medical record. And I worry about the silos, and I've talked to some people on the show who worry about the silos as well that get created. In fact, when we were looking at telehealth systems, and this was a long time ago at St. Joe's, Teladoc was one of the ones that we were looking at, and they essentially said, look, we have our own EHR in this thing, and we'll keep the data separate. And I was like, well, that doesn't work at all for us or the patient. I mean, the patient wants that longitudinal patient record. And so we were talking about sharing the data through the HIE and other things. I'm like, look, I don't understand this. Our physicians were delivering it. And all we were really using Teladoc for was the mechanism for establishing the video visit, the waiting room, and then, just the whole workflow and the process of standing up the technology. So if our doctor's doing it and they're in our EHR and we're just using your technology, couldn't they just document the whole thing in our EHR? And the answer to that was no. So we didn't go with Teladoc at that point. Yeah, I worry about those silos, and I hope that we're not creating more silos as we go down this path, but we're finding ways to bring that whole medical record and all those visits together, because we know that leads to better care all around.
I think most of those applications, that was their model before, is you document within what's happening in the visit, and then we'll send a PDF back to the EHR, but that's not really all that useful.
That's what we need, more PDFs in the EHR. For all doctors out there, I was kidding. No more PDFs in the EHR. Let me hit on another story, and then I'll let you hit, you sent over 2 stories. Love to hear from those. This one I want to make sure we get to. So Ford launches a tech program to address health disparities. And I like this. This comes from Modern Healthcare, is where I picked up this story. Henry Ford Health System launches competition to tackle disparities with tech. Henry Ford Health System is seeking out new ways to address health disparities with digital technology, including a focus on digital divide. The Detroit-based health system said on Tuesday. The system's Henry Ford Innovation Arm on Tuesday unveiled the Digital Inclusion Challenge, a competition that it is hosting in partnership with Google Cloud and Novi, Michigan-based information technology firm Miracle Software Systems. Entrepreneurs and engineers from across the globe are encouraged to propose ideas on how to use digital technologies to reduce racial, gender, and other health disparities that could include projects that make more affordable, accessible or make it easier for patients who don't have access to high-speed internet access and learn about their health. The challenge supports Henry Ford's broader initiatives to double down on diversity, equity, and inclusion, and so forth, which I heard their CEO talk about at the JP Morgan conference. They are very committed to this. The competition kicks off on May 19th with submissions due June 24th. The winning team will receive $75,000 and will participate in a co-development program at the Henry Ford Innovation Center, where the team can collaborate with the system's clinicians, IT, and other staffers. So interesting program. I wanted to give them a shout out. I wanted to get that out there. There's a lot of other innovation programs out there who are doing these kinds of challenges and those kind of things. I like the focus of this one. Have you seen others out there?
Yeah, and I think that's part of the challenge, right? Because there's so many different people doing different competitions to drive some kind of innovation or plug some of the holes that we have. And, whether it's, like this, through some of the disparities, I think, in the way people receive their care. It's exciting. What's interesting for me is we all end up with a technology solution somewhere, right? That's new, or somebody's kind of stitched some things together. But I think it all sort of assumes that the patients, we keep saying there's a shift to consumerism, that they want to be consumers somehow. They want to use the technology differently or more in their care. And I don't know if that's always true. I hate to be a downer on that, but it's just some people, a lot of people, I think, don't want to be in that position. So while I would overmanage myself electronically, because I do that with everything else in my life, I know folks who won't. They just won't interact that way.
Yeah.
And it doesn't help with outcomes downstream, for sure, population management.
Well, that's what I love about these competitions. And by the way, if I were doing a startup, I wouldn't participate in any of these competitions, just for clarity. And I wouldn't coach people to participate in these competitions unless you're doing it out of the kindness of your heart and the goodness of your heart. It's not a good way to start a business. It's not a good way to really get to the next level. If you have a good idea, go get the funding and go launch it. But these challenges are a great way to get a lot of energy and focus. This is how SpaceX got launched. This is how you get 20 organizations, 20 smart groups of people working to get a rocket into low orbit. And once they're successful, they're able to go on and commercialize that. At least a lot of them are able to, if they're thinking right, they're able to commercialize what they've done and those kind of things. And that's the concept here. If nothing else, you'll get a lot of energy around this. I think there are ways, I agree with you. We end up with a lot of technology solutions in silos that don't really integrate real well. And we don't take the community that we're trying to serve into account enough. And I think that's where the generic competition type things don't serve us well. I like this one because of its specific focus. It's saying, look, we're trying to serve this population in these communities in and around Detroit, and it's the people that are disconnected digitally. All right, so how do we help them? And to be honest with you, we know that 80% of healthcare is not health related. It is social determinants and other classifications of activities that we do. But I just don't know how people function anymore without technology. How do you apply for a job without technology? How do you even know that a job exists without technology? As an employer, I never put an ad in a local newspaper anymore to hire people. I mean, I go out, I get people through Upwork and some of those Fiverr and other things for things that we need to do short term. And the other hiring I do, it'll go out through technology platforms. How do these people find out about jobs? How do they apply for jobs? How do they, how do they read a lot of these journals these days? A lot of these journals have gone to digital only. If you are disconnected from the internet, I think that has become, just part of functioning in our society. And if we want people to be healthy, it's almost like we have to figure out how to plug them in. Now, we also know that there's a lot of unhealthy things on the internet as well, like all of Twitter. But at the end of the day, it's hard to function in our society without access to technology, I think.
Yeah, I mean, I totally agree. Like, who really reads the local paper anymore? That's almost a thing of the past. And even our local paper here, which we do still have a subscription to, they've actually stopped printing on Saturdays. They just no longer print a paper, but they're happy to tell you that you still can have the digital edition. So
Yeah.
you can get into that. So it is crazy. And I guess word of mouth, right? I mean, some of those communities, and I'm from Michigan originally, so I'm pretty familiar with Detroit. In fact, I'll be up in Michigan next week. We're going to go visit some family, and I understand some of the communities that they're working with. It's not unlike actually where I live now, pretty rural area. It's, a grouping of islands essentially, and this huge disparity between kind of income levels and in neighborhoods and things like that, which is incredible. So that was always our challenge. The health system I worked at here for 10 years is, how do we deliver care equally to all the folks who are here, from a population health perspective? And it was complex. And we had to go through, you couldn't rely on technology. We had to go through some of the other networks, working with local churches, things like that, because people would, it was meaningful to them, I think. And we had a way to contact and get in touch with people.
Yeah, it's interesting. I think we need to be connected to technology, and then we need places like that where we can get away from technology.
Right. Right.
So, all right, what story do you have?
Which one do we want to jump to first? Let me see if I can grab one of them. Got two that to me are sort of tied to each other, right? So one is, good Lord, we got too many things going in. So EHR usability, and this is something, when I was a CIO, also for 25 years in different places, as we were implementing that technology for what we all thought were the right reasons, doing as good as we could do and things like that, always, and I'm sure you got this pushback from clinicians, you hear, you're going to kill somebody, you're ruining my day, I'm burned out, I'm blaming the technology. And and I know that that's certainly a piece of it, right? I mean, there's a number of things that drive to clinician burnout. So technology is a piece of it, but obviously the reimbursement changes over the years, the expectations, organizations trying to be more lean because they almost have to survive from a nursing perspective, and things make a huge impact. And my wife's a nurse, so I know, the day-to-day of everything that happens from that perspective too. And you can't always do more with less. Technology doesn't plug that gap. EHRs don't necessarily plug that gap. So this was an article recently in the last couple of days, I think, about poor EHR usability linked to nurse burnout and patient mortality in the study. So nurses are blaming the usability of EHRs, and they had a ranking of, or scoring system of EHRs. And so for those, they say didn't do a good job of developing the EHR and good implementation of it, that leads to nurse burnout. Well, I guess it makes sense. I think a good implementation can lead to nurse burnout too of an EHR. The problem with all these studies, I think, is that you never really hear the flip side of what you do. Like, you're delivering data that's necessary at the point of care when it's needed, things like that can help drive decisions. So we all get that. And I think long-term, hopefully quality improves and everything. But the interesting thing about this was it was a 12,000 nurse study on EHR usability and outcomes. And then they were able to go back and look at mortality data for those organizations who ranked it low, and saw that the mortality was higher in those. And to me, that's compelling, scary and compelling at the same time.
Yeah, so I always come about this in two ways. So we covered, nurses gave the EHR usability an F grade last week on the show. So if anyone's interested in that, there's almost a follow-on to that.
Mm-hmm.
The usability is so important. The data is even more important. Well, I mean, the EHR can lead to adverse events. That's a nice way of saying the EHR can kill people.
Right.
I mean, if there's incorrect information in there and people are acting on that incorrect information, there's a lot of checks and balances, and there should be. But if there's incorrect information in there, it can lead to an adverse event. Doesn't have to be a death, but it can lead to a lot of adverse events. So
it's like a paper chart.
yeah, exactly. Incorrect information is incorrect information. That the challenge with an electronic versus a paper is, paper doesn't propagate across as many locations. If you put it wrong into this health system, it's going to go to the HIE, and that's going to go down to the next health system, and then it's going to, who may not have the same kinds of practices that you have to catch errors. So electronic health systems, electronic mechanisms tend to create larger problems just because they can propagate it so quickly. It's just moving ones and zeros all over. But yeah, so there is that aspect of it. It absolutely needs to be looked at. It needs to be done well. But then I hear the other people who are saying, look, the earlier comment, we should go back to paper charts from the post that I did this morning or last week. And the challenge with that is, and I've had people say to me, there's no studies that show the EHR has led to any health benefits or any reduction, and it's just not true. And we can go back to early on. We found all the information. We stopped using Vioxx as a result of the electronic health record. The electronic health record was able to bring all that information together. People started looking at it and saying, look, we're administering Vioxx and people are getting sicker and dying. And this is across this whole patient population. So they were able to capture that quicker, stop doing that, and then move forward with, a different direction. So the EHR has saved people, can save people, but it needs to be built right. And this is the thing I know that the average American doesn't understand. And I think most people in healthcare understand. The build is highly dependent on the health system that's implementing it. And this may not be as true in an Epic case. This is why Epic is so popular, because Epic has become very prescriptive. This is the build we recommend, the standard build that we recommend. This is the foundation that we suggest you go on. If you're not a large health system, we suggest you go on Foundation. And if not, we suggest you find a Community Connect partner who can do the build correctly and go in this direction. They were very prescriptive. But before that, a lot of EHR providers would come in and say, we've got this technology. Bring your people together. Tell us what you want. Build it how you want. And to be honest with you, we weren't good builders.
No, I don't think we understood what the endpoint was. And then, and so I completely agree. Almost, don't you wonder, shouldn't we even have less variation in the EHRs? I mean, a lot of those studies you're talking about that show the quality outcomes. Why? Because we reduce variation in the way we deliver care. And, I know there's the argument from the clinicians about patients are individuals and all these unique, so the art and the science piece of it together. But every study that looks at all the right data, if you reduce variation in care, you're going to have better outcomes overall and probably reduce expense to the organization, which we need from a healthcare perspective overall and all those things. So I almost wonder, you can't say, all right, I'm going to call Microsoft and order my version of Outlook to be like this, whatever this is. What if we didn't have any ability to have the workflows so different from organization to organization in an EHR, and some have more flexibility than others, but they all do. I mean, even in Epic, you can go down the wrong path if you want to, for sure. Don't you think it'd be better? I mean, that would scare people, I suppose, and there's almost no way to get to that point.
Reducing clinical variability is important, but you've done a build, I've done builds, and it's so challenging. My gosh, you sit in that room with 5 oncologists and you say, okay, let's get to the way we're going to practice. And they come back to you and say, all right, these are the 3 ways we want to put into the system. And you're like, you couldn't agree on one. And they just look at you and say, no.
And they might be partners,
Yeah, seriously. Orthopedics. Hey, we want you to narrow it down. Right now we have 5 different manufacturers we have to deal with for hips. We want you to get down to 1 or 2. Yeah, we couldn't do it. You couldn't do it? It's like, yeah, we don't agree. It's like, well, wait a minute. That variability is costing everyone a lot more money. So are you telling me that this hip is that much better than this hip? While these 2 think this hip is better, and these 2 think this hip is better, and these 4 think this hip is better, and they're not going to change. Okay. So and at the end of the day, that it's really, I think it's a lot harder than what people think to do a build.
Sure. I mean, all of those implementations to be good, it's not a technology problem. It's a culture problem, I think, that you're trying to overcome. And, that's where you have to spend most of your effort. And, education of what you're doing, communication around what you're doing, why. But even at that, it's impossible. And the larger the organization, you probably the more complex it is, and the more people you've got with voices in it. Even though you would think they'd have more ability to say, "Here's how we're gonna, deliver care here," it doesn't work that way. And it is crazy. And the competing priorities. Those providers might also have a clinical director relationship with a different vendor, which means that they're getting some sort of compensation, and doesn't mean they don't like that. Is they can't validate that that's a better solution for them, but definitely changes the way people look at things.
How can so? I mean, this study and the nurses. I mean, this really focuses a little bit on the nurses. How can we ensure that the nurses are being represented in the build so that it does serve them better as a group?
Yeah, and I don't know if there's any silver bullet. I mean, clearly, most organizations now have a lot of nursing staff people in the IT staff and then through the governance of the organization. When everyone's got like a CNIO kind of a position that's a peer to some of the others in the organization from an IT perspective and organizational, I think that's helpful. CMIO now is pretty common. 10 years ago, it wasn't. A few places did. Some people had part-time or people that might help, but they weren't really an executive level role. And I understand you're probably ruling out real small organizations, but medium and larger, that's just a common thing. I think the CNIO is a great place, certainly having CNOs engaged in the entire process, because you have to, and you can't just do things in a vacuum. And I remember the good old days when you'd say, "Here's how the system worked," and the reality was, "Here's how we work." You can't tell us because that's what you programmers built. That's the way we deliver care.
Hey, let's hit on a topic that I know is near and dear to all of our hearts, and that's patient matching.
Ah,
So, interesting article. And granted, I think this is written by somebody who runs an HIE. Sean Alfred's executive director and CEO of Health InfoNet, an independent nonprofit information service organization that manages statewide HIE in Maine. The reason I do that is I now read articles and I look for, is this a sponsored article? Who wrote this article? What is their
right.
lens that they're looking at this? So it is an HIE lens, but I think it's interesting, and I think it's a topic that we don't talk about enough, and it's a challenge. So the title it comes from Healthcare Innovation Group. Is your organization making avoidable patient matching errors? And then it goes on to say, imagine there's three people named Sean, three different spellings, walk into a hospital. While this may sound like the start of a joke, it's no laughing matter. It's seemingly harmless clerical error which takes place. This could jeopardize the accuracy of the downstream patient matching. When an electronic health record receives a misspelled name or a duplicate record gets created, there could be a misunderstanding about medications, miscommunication of follow-up instructions, or delays in care. The result of miscommunication between caregiver during patient transitions can include readmissions, patient harm, or inadequate informed consent. And this is research from Circo Strategies indicates that such communication failures have led to nearly 2,000 preventable deaths and 1.7 billion malpractice costs. Wow, that's a lot. To improve healthcare outcomes for patients and reduce costs for providers and payers, we need to improve patient matching. Amen. Okay. So now they say, here are some lessons learned and key opportunities for organizations to consider in order to achieve more seamless clinical data exchange. All right, so be ready for this, because I'm going to come back to you and say, what can we do around patient matching? So the first they give is involve patients in their data validation and registration. In other words, take down the information, turn it around and say, is this right? Is this accurate? Or better yet, have the patient actually input the information. Figure out a way to use the patient as a data steward. Number two, establish cohesive data governance. All right. So what they're saying is all health systems and their IT vendors need to use the same terms, definitions, and processes while compiling patient records and interoperability and more efficient care it leads to is possible, but we need effective structures in place to make this a reality. Okay, so establish cohesive data governance. Next one is commit to technology investments. And the fourth one is establish strong partnerships, build an expert team that can tackle these daunting matching challenges. Let me start with the obvious question. Is patient matching still a problem, or have we solved this? I mean, it is 2021. Patient matching is solved, right?
Seems pretty simple, right? About like voter ID, man. Like it somehow became a political problem a long time ago and not just a technology and a people process problem, and so I'm a great example. So my name is Edward Ricks. For my entire life, I get called Rick Edwards, Ricky Edwards. It's just one of those things. And then you probably know there is a Rick Edwards that's been in healthcare IT for the last 25 years, bouncing around like me. And we used to get each other's email from vendors all the time because you start the autofill and it goes, and just like that, it's gone. So, clearly there are some technology solutions. It is process though. It's people and process. The read back, all that stuff makes sense. I don't know if you guys played around with any biometric authentication at registration points of entry. That can help. Some people are worried about that and scared of it. I don't understand the pushback of a patient ID, a universal patient ID. That would help, right? But there are so many like points of egress to make the mistake. So registration is one point. So you could make an argument that that's maybe one of the most important roles in an organization. And I will also counter argue that's probably one of the lowest paid roles in an organization. But getting that information correct from a clinical perspective is one thing. From a financial perspective, from a billing, medical records, claims process, all that stuff is just a critical job, and it's complex all the time. So you've also got the families with multiple people with very similar names. You've got people who will lie because, my brother has health insurance and I don't, so no, I don't have any ID, but my name is whatever, so there's a host of reasons I think that it's a problem. I like the biometric that can help. That's not the only answer. And again, some people won't use that or don't like it. I don't know why it's still a problem. It is still a problem. But it's also a problem after registration. I mean, when you're taking care of a patient, you still got a clinician at some point selecting the patient. Now, a lot of the workflows sort of make that almost fail-proof, but it's not. And it happens all the time. Select the wrong patient, do orders, and it's done.
And I'm sorry, I'm giggling over here. I'm giggling because it's still a problem because it's interesting to me. We did a lot of things. One is, yes, it is one of the lowest paid people doing the process, but anytime you have the lowest paid people doing the process, you put in systems that have checks. And so we used, I think it was called Initiate. IBM had a thing called Initiate, and it did patient matching on the fly. And so if a person tried to put you in as Rick Edwards, it would look at the information and go, we have a person that looks an awful lot like this person named Ed Ricks. Are you sure you want to create another record? And then they would go, yeah, they're flying, they're trying to do it as fast as they can. And it goes a little further. And there was another one that would pop up and say, no, we're pretty sure this is Ed Ricks. This is not Rick Edwards. Are you sure you want to do this? And they would go, yeah, go ahead. You know what? If they said, yeah, go ahead, that created a log file that went to their manager that said, hey, they created a new record and we told them twice that we thought this was this person. Now it was that manager's job to validate, is Rick Edwards Ed Ricks? And if they said yes, then there was a training initiative that had to happen for that person. Hey, you're working too fast. You're trying to move too fast. Or do we have too many people lined up in the ER? Do you not understand the job correctly? And all those other things. I mean, like you said, it's people process. It's not that hard to do. And the technology, the Initiate technology works with just about every EHR. It wasn't that hard to implement. Did we have duplicates? Yes, we had duplicates. We did. We had people moving too fast. We had people that you just wouldn't expect, right? So somebody from we were in Texas, California, Northern Cal, Southern Cal. Somebody from Texas went to Disneyland, showed up in one of our hospitals in Southern California, and people would just say, no, that can't possibly be that record. Well, at the time, what we had 8 different EHRs. So that's one of the main reasons we had duplicates. When we got to a single instance of that EHR, that went way down because the Texas patients would show up in the Southern California EHR and vice versa. I just want to go on the record here of saying I am for a longitudinal patient record. I want all my information to be able to be aggregated, except I want the patient to be the locus of that. And I don't think that requires a national patient ID. Now, national patient ID might be required for research and other things. Somebody can convince me of that. I'm more than happy to listen to it. But I don't want the health systems to be able to aggregate my data. I want to aggregate it all myself. And when I show up, you say, do you have your health record? And I go, yeah, here it is. Care for me. Because you know what? I'm the constant at the point of care. I know if I'm seeing Teladoc and you don't know about it. I know if I'm seeing some homeotherapy and you don't know about it. I'm the constant at the point of care. I want to be the aggregator. And you know what? If you want to aggregate it to my phone number. People are like, oh, they could hack that. I'm like, I have more confidence that they're not going to hack this iPhone,
Right.
and they're not going to hack my health system. So I want to be the aggregator of my patient record. I don't want it to be honest with you, when I leave my hospital, I want to say, take it out of Cerner, take it out of Epic. I don't want you to hold it. Because you know what you're going to do? You're going to sell it. And they're like, oh, we don't sell it. I'm like, I have story after story of health systems that are selling data. Mm-hmm. And a lot of them don't even know it. I'm not pointing a finger and saying you're doing this on purpose. Some of them don't even know it. It's like embedded in older contracts. You know, my favorite is Explorus. Explorus had huge amounts of contracts, and they sold to IBM for, I don't know, $500 million or whatever. And at one point, you know, we were looking at their revenue stream because we were an investor. And I'm sitting there going, what's this revenue line over here? And it was almost half their revenue. Like, oh, we sell patient data to blah, blah, blah. I'm like, what patient data? Right. Essentially, the patient data they were getting from their health systems, they were selling to pharmaceuticals and others. They're like, oh, don't worry, it's de-identified.
Right.
I'm like, okay, I didn't know it as the health system. I know the patient doesn't know it.
Right.
And it's like, oh, well, don't worry, it's de-identified. Well, let's let everybody else decide whether it's okay. It's like, well, it's in your contract. I'm like, okay, well, we need to read the contract again. And I guarantee you, people are still, I think IBM probably is still making a significant amount of money that way, and as are others that are making money that way. And I don't want you to comment on it. I don't want you to get in trouble. I'm just saying, at my experience, I really do want, I don't think I need a national patient ID. I think I need, what I want is a shift in how people think, instead of, hey, we need to be able to aggregate all these at the health system. No. Aggregate it all at the patient. And then let the patient decide, do I want to participate in a research study? Do I want to share this with the National Cancer Foundation? Do I want to share this with the Biden Cancer Initiative? Do I want to share this with the American Heart Association? Do I want to share this with the local hospital? Who do I want to share my medical record with? I think that would be a significant shift. And, I led you in a couple of directions that could get you in trouble. So I apologize for that.
I get myself in trouble without your help. Don't worry about that. No. And I like that, but do you really think most patients are ready to take that kind of ownership like you are? You're sophisticated, right? And you worked in IT and healthcare for a long time. So you want to manage that. I think a lot of people don't. That's a comment I made earlier. I'm not sure every patient wants to be a consumer in healthcare. I think they just want to go get care when they need it. Yet we were talking golf yesterday. So next time you and I, if we go golfing, first of all, I'll warn you, stay way behind me because anything could happen, right? But say something funny happens and I hit the tree and it comes back and knocks you out, and EMS hauls you in, you're not going to be capable of managing what information there because you're on vacation. And, it's one of those things. Don't you want like all of your record to be available? I would love anyone to be making an informed decision at any point, which I think most people do.
And I've been having this conversation. I've been in healthcare for a decade. I've been having this conversation for 8 years. We do break the glass all the time. It's not that hard.
Yeah.
So, in case of emergency, here's how you get access to my medical record. We solved that problem probably 2 decades ago. So it's not, again, that's not the argument against it. And in terms of anytime people say, hey, anytime they belittle the consumer, and they say, hey, the consumer's not ready for this, they don't want it, and that kind of stuff. I say, okay, you know what's going to happen in that case? Somebody's going to step in. And it can be the health systems. The health systems can say, look, do you want us to house your record on your behalf? And those who don't want to be consumers can say, yep, by all means, you house it, I don't want it. But for the rest, you can, it could be the health system providers, it could be others that step in. It could be big tech that steps in and says, look, we'll be the ones who house your medical record for you. And because we know how to create APIs, we know how to share this with the people you're trying to share it with. We'll create a better user experience than you would ever get from a health system or some other player. So go with us. And then you create competition for who is going to be the trusted broker of the information in the healthcare ecosystem and not be dependent on, there's only one today. We are told that there's only one person you can trust with your health record today, and that's the health system. And the problem with that is my health record is all over the place, including on the dark web. So I don't think I don't think we can say, we are, we should be the only purveyor of the health record. So
yeah, no, I mean, I'm buying what you're saying. I just, how far out do you see that shift? Because that's a big cultural shift too. It's not just technology. That's pretty solvable, I would think.
The difference between where I'm at today and where I was as a CIO, we were developing a lot of the tools we were developing was around these concepts. And we had some really cool startups doing things around that. So that's what I would have done in the CIO role. From the concept of how do we empower the patient, that's what I would have done. What I'm doing in this role, I can look 10 years out, right? I'm trying to influence. I just want one person to hear this conversation and go, that's interesting. I wonder how that would impact the next project we do. I wonder if I introduce this. And so as I finally embraced the fact that I'm media, I say I'm a former CIO, but I am media. And as media, how do I get more people to, to not even embrace? I don't want people to all agree with me. I want people to engage in the dialogue. Is Bill right? Maybe he's right. Maybe he's wrong. Let's have the conversation and see where it takes us. That's what I'm trying to do here. I'm not trying to change the world or anything. Actually, I am trying to change the world, but that's.
Yeah, no, I love the concept.
Hey, Ed, thanks for coming on the show. We went a little long, but I always like getting together, and we will have to do this on a golf course the next time around.
Yeah, no, that'll be more fun probably, but I appreciate it. Sorry about my dogs. At least, so we have a cockatoo. At least he didn't start going off on the phone stairs, because you would really know that one.
You make it sound like you live in a zoo of some kind.
No, it's close.
That's great. Hey, that's all for this week. If you know someone that might benefit from our channel, please forward them a note. I know if I were a CIO today, I would have every one of my team members listening to this show. It's conference level value every week. They can subscribe on our website, thisweekhealth.com, or they can go wherever you listen to podcasts, Apple, Google, Overcast, which is what I use, Spotify, Stitcher, you name it, we're out there. They can find us. Go ahead, subscribe today, send a note to someone, and have them subscribe as well. We want to thank our channel sponsors who are investing in our mission to develop the next generation of health IT leaders. Those are VMware, Hillrom, Starbridge Advisors, Aruba, and McAfee. Thanks for listening. That's all for now.